where this is not an acute issue. So let me then talk about some of the possibilities. So I'm going to start off with the good stuff. So there are three things that I'm going to highlight, and then I'm going to highlight three challenges as well. So the first one, since this is a public health crowd, I can't help but talking about the possibility of early warnings of pandemics. And that is something that we should absolutely be able to take advantage of AI to learn about. The story that I keep in my mind is that if you want to know where the next pandemic is likely to come from, one good thing to do would be to keep track of chicken prices in Thailand. And so that's what I've shown you. Here's a chicken market in Thailand. And you say, why is it that a chicken market in Thailand is going to do anything for you? And the answer is, as best I can understand it, that it's possible that the next pandemic will start by killing wildfowl in Asia. And the way you'll pick that up is that chicken prices will go up in the market. So therefore, one should be monitoring chicken prices around the globe to get some indication about, is there a problem with wildlife? So that's just one example of where you can train a machine to say, look at these, here's a bunch of indicators, see if you can use them to pick out when you're having problems, and then alert us to them. So that's the first possibility that I'd like to see. The second one that I would like to see is simplified administrative processes. When I think about medical care systems and AI, I really want to differentiate the administrative side and the clinical side. And the administrative side is actually, I think, where the first big impact is going to be. US healthcare is distinguished by its enormously high administrative expense. So the biggest single cause of higher medical spending in the US than other countries is higher administrative costs, not higher drug prices, or although they contribute, and not more care, although that contributes as well, more images and things like that. But it's the administrative side, and a lot of that is people. So a very common thing that a person does is takes computerized information from an electronic medical record and type it into a different form for a billing system. Well, the minute I tell you that one person is taking information from one record and making it be in another record, then you should think, gosh, why isn't the computer doing that? And that's exactly what some of the natural language processing and the AI can help us do. So I would look to see fairly big improvements in administrative costs. Many health systems have entire buildings devoted to people just for billing and processing and prior authorization. And I would like to see a situation where we don't need those people, and instead we can do it through electrons, because electrons tend to be a bit cheaper than people are these days. So that's the second area of possibilities on the administrative side. The third area is on the clinical side. And what I want to think about here is the possibility of using AI to do diagnosis cheaper. So we have all sorts of situations in rich and poor countries. This is in rural India, where we're trying to diagnose something. Maybe we're trying to diagnose a form of chest pain or angina, or maybe we're trying to diagnose diabetic retinopathy or something. And we have some data that are great, but very difficult to obtain. So the data might be from a hospital that does an EKG, or from a brain scan, or from a blood test, a very detailed blood test. And it's just not possible, either for financial reasons or access reasons, to do that for everybody. On the other hand, there are often cheaper things we can do. So you can have, for example, a one lead EKG attached to the chest and a cell phone that can pick that up. Or you can have cell phone attachments that will get a guide to heart sounds and lung sounds. And then those are not as good as what you can get in a hospital or a doctor's office. But the question is, can you develop AI to then turn those into something that's much better? You're unlikely to ever be perfect, but the question is, can you do well enough so that in areas where access is poor, here in rural parts of the world, but even in richer countries, there are areas where access is poor, can you find ways to do better, cheaper through the use of AI? So all of those are on my possibilities, and that would have phenomenal impacts on public health, oftentimes save money as well. On my pitfall end, I will also give you three things. The first one is hallucinations, and I don't refer to myself in this, although I do sometimes hallucinate if you listen to folks, but I'm thinking about the AI programs. So they do have this problem, which is that many of them hallucinate, they make things up. And so we're going to have some truth. If you go back to the billing form, just to take the very simplest example, if the insurance company doesn't trust that the AI has submitted a correct bill, given what was actually done, then nobody's going to want to pay attention to what the AI says. So we're going to have to discipline the AI that way. The second one I call avoiding embedded isms. What do I mean by that? The medical system is full of racism, sexism, ageism, discrimination against people with different sexual orientations and gender identities. And so that's all going on. And sometimes what we say is, well, I want the AI to mimic what a doctor would do. So I want the AI to mimic what a doctor would come up with, what a radiologist would come up with. What you're looking at here is an image of knees for looking at knee pain. But in fact, doctors have all sorts of isms in what they do as well. So they're more likely to diagnose things in upper middle income people than in lower income people. And they're more likely to pick some things up in men than in women. And so you want to train AI to ignore that. But the key in that is not to say, well, I'm going to ignore race of the patient. I'm going to train AI to predict what the doctor would do, because the doctor himself or herself may be acting in a biased fashion, knowingly or unknowingly. And so you need to train to the ground truth. In this case, how much pain would a person have with a given knee image, not how much pain does a doctor think a person would have with a given knee image. That latter one has got a lot of bias seeped into it that the former one does not. And so this, I sort of think of this to remind me that, if you train an image to figure out who's got pain and therefore who should get a knee replacement if you have knee pain, it'll allocate many more knee replacements to people with lower incomes and racial minority groups than will standard methods of just looking at an X-ray and deciding what to do. Finally, we want AI to be neither overused nor underused. And here there's a particularly important economic issue, which is how we pay for the AI is going to be really, really important. So if the clinician has to pay for the AI, then somehow we have to pay to cover the cost of the AI or it won't be used. So think about AI that's used embedded in a particular technology. On the other hand, if the AI kind of comes along for free, as it were, that is, you buy the retinal scanner and then the AI reading of the image comes along for free, then you don't necessarily want to pay extra for the AI component because the docs will just sort of do way too much of it. So just like with any medical technology, when we come out with a new drug for patients, we want to use it for the people in whom it's appropriate and not use it in the people for whom it's not appropriate. What we discover almost all the time is that we use it in more people than should use it, so we overuse it. And we use it, and we don't use it in some cases where we should use it. That is, we underuse it. And typically that's accompanied by reimbursement incentives. That is, the people who are overused are paid well, and the people who are underused are paid poorly. So unless we get the economics of it right, there's very little hope that we will get the clinical components of it right. And so I want to stress some of the economic components here. So that's my sort of list of possibilities and pitfalls. And then the question is, can it be done? And the answer is, well, I don't know. You look at this graph and tell me what this graph tells you is the share of the population that received sort of the latest technology, which is mRNA or some form of COVID vaccine. And on the one hand, like, the world did really, really well because, like, there are vast, vast parts of the world where the rates of receiving at least one dose are extremely high. And then on the other hand, the world did very poorly because there are vast, vast parts of the world where the rate of being vaccinated for COVID is much lower. So many times we observe that we can do things really well. We can get, antiretroviral medication to people who are HIV positive around the world. We can do lots of things well, but then some things we sort of don't finish it up and we don't do it right. And of course, that all depends on the incentives that we put in place. So I'm hopeful that we will figure out at least some of the economics here so that we can get more of the technology to do what we want. And I think I will just stop there and thank you again so much.
Absolutely fascinating. Thank you so much, Dr. Cutler. Dr. Nelson, now it's over to you. And I believe you're muted, unfortunately.
Apologies. Thanks, Jennifer, for the introduction. Thanks to Dean Galea for the opening remarks and the invitation to be here in today's conversation. We're talking increasingly about broad, AI with broad use cases, but the particular use cases really matter. Domain expertise matters for how we benchmark the possibilities and perils of these tools. And so I'm delighted to be speaking with a group of people, all of us with a shared interest in public health. So we were asked to consider the role of artificial intelligence and the health of populations, as well as how AI can be used in public health for good or bad consequences, and to think about those potential use cases. Delighted to be in a conversation with David and my former colleague Greg about these really important issues. I approach these questions as a recent political appointee in science and technology policy in the Biden-Harris administration, where I worked on AI policy, among other things, and also as a sociologist of science and technology and medicine. Applications of artificial intelligence have been in most people's lives for several years, but it was when OpenAI's ChatGPT was released in November of 2022 that the world took notice of AI in a new way. We know now by the start of 2023 that more than 100 million people had reportedly used ChatGPT, and we can presume that millions of others had engaged in some way with some form of generative AI. So what I want to say as a kind of a headline of our conversation today is that the public, because we had these tools that were really enterprise tools that were kind of coming in the background of our lives, allowing us to open our iPhones with our face, aggravating us when they were doing bad autocorrect and they were trying to send a text message quickly to a friend or a colleague. We weren't really thinking about AI and public discourse really in a major way. After the fall of 2022, the public became a major kind of stakeholder with very active interest in thinking about the uses of AI. And so I want to suggest that the public and public health took on a new kind of renaissance, a new resonance and a new relevance for how we think about its uses, different from medical technologies that we have been introducing in public health for decades, right? Now the public was being asked to look at this, to think about it in a new way. So this moment that started in the fall of 2022 occasioned, I think, heady excitement on one hand, grave concern on the other, a lot of it documented by the media, some media that had been writing about AI and technology for a long time, some in the business space, some in the culture space. So we also got a lot of the media reporting, trying to create a narrative out of something fairly quite abstract and frankly quite, I think, nerdy in some instances, with obviously profound implications. So we were warned about rival camps in the AI community. We were warned about existing harms and foreseeable risks. Some people called for a course correction in the trajectory of the deployment of advanced AI, while others are spurring on AI developers to just go without concern for risk. So it's in this backdrop that the public, in which the public has been engaged, listening to all of this communication about AI, that we really need to think about, I think, today's conversation about the implications of AI for public health. So let me say I have tremendous optimism. I mean, some of the things that we hear about AI, our highest aspirations for it are about curing cancer, or about, as Dr. Cutler was referencing, expanding radically access to care. These are things that we absolutely must do. But it's also important that we know that none of this is the inevitable outcome of any AI technology, whether or not you're talking about neural networks or deep learning or so-called predictive technology. None of those tools inherently are going to lead to the outcomes, the beneficial, the pro-social outcomes that we want. There is no inherent quality to AI that will make them benefit society. So we've got to steward their use to beneficial outcomes. And policy is a key aspect of this, and I'm proud to have worked in that space, and I imagine that Greg will have had lots to say about that. Today, I want to offer just 4 additional observations for our conversation about AI and public health. The first is, don't believe the hype. The second, consider workers. The third, consider patients. And then I'll say a little bit in the end about professional responsibility. So opportunities to expand healthcare, I think, will multiply if we are not caught up in the hype, or only thinking about the technology as accomplishing the social outcomes, the public health outcomes that we want. It is the case that these technologies can help tremendously. Dr. Cutler mentioned, COVID-19. I was curious to read and have been tracking research using AI and deep neural networks to analyze lung-based ultrasound images to sort of see if you could diagnose COVID-19 early on. This is early days. This was research that was published just last month in Communications Medicine. I think that, this again, early days, there's a lot to see what's going to happen with these tools, but we could have imagined in the early days of the pandemic being able to try to use a tool like this to help us get more traction and understand what was happening at a moment of a high water mark of a pandemic. So that's immensely promising, but there's much more to be done. But we also have examples in which I think we get caught up in the hype. So in 2016, the prominent computer scientist Geoffrey Hinton famously opined, and I'm quoting him here, "We should stop training radiologists now. It's just completely obvious within 5 years, deep learning is going to do better than radiologists." So that's 2016. He said 5 years. We're now in 2024. It was the case that by the end of 2022, we had more than 200 FDA-approved radiology AI algorithms. So it was the case that there was a lot of technological change happening in the space of medical technologies to be used in public health. But we also, at the same time, had historic shortages of radiologists, right? Both for training issues, because you had people who were overworked and burnt out. And so I think that we can't just take prognostications about technology as being the outcome that we think might happen or fear is going to happen. It's clear now that what is likely the case is that AI is going to be a tool to augment the work of radiologists, right? And that it will add value and potentially save lives. So there's some evidence from Nature Medicine, also from last month, that suggests that using AI to augment the work of radiologists might improve the performance of some radiologists, but it might worsen the performance of others. So which is to say that instead of, I think, coming out of the gate with new technologies and being caught up in the hype cycle, let's learn to speak with nuance about what these tools might do and might possibly do, because as I was trying to flag at the beginning, patients are listening. They're paying attention now for the very first time to how we talk about AI. And this is shaping their expectations. So what this study from Nature Medicine, March 2024, suggests to us is that we shouldn't look at radiologists as a uniform population, that we've got to think about if we want to maximize benefits, minimize harm in the use of assistive AI technologies in radiology and elsewhere. We actually have to think about the people, and we've got to go back to things like machine-human interaction and thinking about how these tools are actually used. So again, don't believe the hype, but, I think have optimism, and but talk about these technologies and their potential in a much more nuanced and complicated way. And that doesn't mean that one's not optimistic about what AI might promise, but it means that one is more forthright and honest, and that matters for people's lives and their experiences and health and sort of a health context. Second is to consider the workers. So I think one of the it wasn't implied, I think, in the framing questions that we got, but part of what's happening in public health and the implications for the health of populations is how the medical workforce is changing, the workplace is changing. And we saw, President Biden did an executive order on artificial intelligence last October. And, I imagine that Greg might have something to say about that, because there was a lot of call out for what HHS could do and what could be happening in health. But I wanted just to flag for our conversation that the executive order also talked about work and workers, right? And it said that workers shouldn't be subject to undue surveillance, that there shouldn't be new safety risks or health risks introduced into their work by the use of AI, that we need to consider labor unions and employers and educators need to be in the conversation together. So I want to sort of raise up the public health workforce to be included in how we're thinking about this AI transition, and as we're thinking about the potential perils and possibilities of what it might do. Some of you might have followed the reporting from last year, but there's been lots of it. I'm thinking specifically about Wall Street Journal reporting from June of 2023 that reported on nurses at UC Davis Medical Center and at Brigham and Women's Hospital who felt paralyzed in their own decision-making by the introduction of AI tools and systems in their work. They didn't feel like these were assistive technologies. They felt like that these were technologies that were put in place to make them question their judgment. And they also felt that they had implications with regards to liability and their own personal responsibility and being penalized if they felt like they made the wrong decision. And so if we think that these tools can be beneficial, in one case, one of the nurses was working in oncology. If we want to save lives, in those cases, we might not have cured cancer, but if we want to help people live longer lives, we need to figure out what the relationship it should be between nurses and AI assistive technologies, and to take that very seriously and not just introduce them into the workplace. So prioritize and consider the worker. Thirdly, prioritize and consider patients. I want to talk here. Some of my work has been writing about histories of mistrust and distrust in public health and medicine, particularly from the perspective of communities of color and African-American communities. So these new AI tools and systems, as Dr. Cutler say, enter this world of isms for good and for not. We know that the mistrust that already exists already has implications that we struggle with every day for people's health-seeking behaviors and for their health outcomes. With the introduction of new forms of AI to healthcare, and in ways that, AI had been in healthcare for a long time, but as I said at the beginning, it is now being, the public is now well aware that AI is being introduced to nearly every facet of their life. So patients might not have been aware of the use of a predictive algorithm in the healthcare space or in public health 4 years ago. They're more aware now. So we face the risk of a compounding of mistrust and skepticism because, as we know from some recent polling, the American public in some instances has mistrust of medicine, and we're starting to learn from the new polling that they're not sold on the benefits of AI. So in February, KPMG did a survey that suggested that most people are wary about trusting AI systems or have low or moderate acceptance of AI. This is, as I said at the top, dependent on certain contexts, so it's worth thinking about use cases. So there's less trust for hiring. If you're using it in resume screening for hiring, the American public is less trustful. They're a bit more trustful for medicine, but there's still some distrust there. People recognize the benefits of AI, but only half of the people who've been polled in this KPMG poll believe that the benefits outweigh the risks. So as we're thinking about introducing AI into the public health system, we have to think about how we do that without compounding and exacerbating the mistrust and distrust that people already feel when you have the intersection effect between conventional mistrust and particular skepticism around AI. I'll just a little bit more data. The Pew Research Center has also done some polling around Americans' attitudes about AI. They found that 6 in 10 Americans say they would feel uncomfortable with their healthcare provider relying on AI to help care for them. Many of the people that they polled expressed concern that AI will make patients' personal relationships with their providers worse. And then there's a general concern about surveillance and data privacy. So consider the patients. Lastly, I want to say a word about professional responsibility and ethics. As Dr. Cutler said, generative AI systems and tools are brittle. They don't always work. He mentioned so-called hallucinations, which is, also another way of saying fabrications or inaccuracies. And, it is the case that some of these tools are being released without what I think many of us would think is appropriate testing and safety testing for use in clinical care or public health settings, right? So one, I think, can be reasonable and perfectly fine with the introduction of a generative AI tool for, leisure time, or to write a cover letter, or to, give you a sonnet that sounds like Shakespeare based on your favorite ice cream, or whatever the kind of fun things that we use chatbots for. But I think when we're talking about clinical care, public health settings, that the bar's got to be higher. It's always been higher. It is why we have in health the only federal privacy law that we have in the United States, which is HIPAA, right? We don't have a general law. We do have a law in health. Hopefully we'll have a general law soon. So I think that the introduction of these tools that are not tested and designed for the public health setting confuses potentially the question of who has a duty of care, right? So it's turning over to the public health system to figure out how to test these tools and these systems. And I think that's fine if that's what, I think colleagues and organizations and institutions want to do. So I've been tracking, again, since last month, the emergence of coalitions like the Trustworthy and Responsible AI Network, or TRAIN, which is engaged in developing evaluation standards for medical technologies and for the effective and responsible applications of AI. I think it's an extraordinary effort. It's a partnership of many major healthcare providers in partnership with Microsoft. But I think we also want to pose the question, is it their job? Before the technology is released, was it the job of the particular company or the developer to make sure that those tools were responsible for this particular public health application. But again, I think what the work of Train is doing is extraordinary and important. But I also want us to think about how the ecosystem, about the duty of care, who is responsible for making sure tools are safe and effective, who's responsible to the patient, is I think getting a little bit scrambled in this new AI public health ecosystem. I don't have any answers, but I think I would love to talk about that and we're thinking about. So in sum, I think that advanced AI represents a real wholesale change to the ecosystem of public health, from the role of medical professionals to the expectations of patients, to the responsibility of workers, to the very way that we think about professional ethics. Is it my responsibility? Am I ethically responsible or culpable for the use of these tools at my workplace? And I think that in addition to this, and Dr. Cutler mentioned some of this, we're seeing AI be introduced into how we do billing. Of course, there are things like electronic health records, drug discovery, clinical decision support, communication with patients, remote patient monitoring some of the work that Fei Li's been working on, and of course, things like robotics, which might make, lots of procedures, both rote and very kind of delicate procedures, more widely available to lots of different people. So I think to the bigger question of AI and public health, we need to be thinking about all of those ecosystems pieces, and not forgetting the things that we need to remember about how important it is to include workers, to include the perspectives of patients, and lastly, to never assume that the tool alone, that the AI tool, the system, the chatbot itself is the answer to the challenges that we face. Thank you.
A number of incredibly important points there, as well as just a very interesting conversation I think we're going to have ahead. So thank you, Dr. Nelson. Let's now turn things over to Mr. Singleton.
All right. Good afternoon. Thank you, Jennifer. So glad to be joining you all. Thank you to Dean Galea, Dr. Cutler, Dr. Nelson. It's so great to be interacting with you again. It's just great to be here in another link I have to BU is in 2007, I got to sit in the audience and watch my wife go across the stage at BU and get her MBH from the School of Public Health right there. So it's just so great to be able to engage with the community once again. But, what I'm going to talk about, I want to talk about, some of the dilemmas we face as we're looking at artificial intelligence and public health. I want to talk about, how we think about artificial intelligence, some things we're doing as federal government, and some things we're excited about. Because, ultimately we are looking at these tools to improve, I think that trifecta of care for the American public. But, going back to the theme of the talk, we, caught between the promise and peril of artificial intelligence. We are caught between our imagination of what the far future of AI might be versus the possibilities of today or the near tomorrow. And as one way to illustrate that, I was talking to my son. He's a teenager and he watches a fair bit of Marvel movies. And so one time we were talking and walking, and he says, "So, Dad, you're working on AI for health for the government, right?" I'm like, "Yeah." He's like, "But in all the movies, the AI ends up being evil, right?" And I'm like, "Well, hold on." I think Dr. Nelson accurately cited the academic research reflecting some of those attitudes, but there is this common perception or this sense from our media, well, AI could do great harms. I think one of the important messages we have, out of the Biden administration, out of the framework for a Bill of Rights of AI, out of the Executive Order 14110 on safe, trustworthy artificial intelligence, is that the role of the government, my role, what we're here to do is to be on the field, to be in the arena. And so we are guiding and shaping the AI so it comes out to productive outcomes. As again, Dr. Nelson said, there's no guarantee that AI causes either benefit or harm. It's up to us as society to figure out how we engage with these things and how do we shape them for good. But I do want to talk about why AI, if it's so sensitive or we're concerned about it, why leverage AI at all? I ask people to think back, where are we in society? And, where are we today versus where we were 20, 30 years ago? And over the last 20, 30 years, the volume of data, of information, of communication that's computed, stored, transmitted has just increased exponentially. I mean, literally exponentially, and it will continue to do so. But when we look at our institutions, our organizations, and the workforce, that hasn't increased that much. That hasn't kept pace with that volume of stuff out there. So how do you handle that? And this is true all across society. It's true in health and media and everywhere. If you have the same workforce, you've got more stuff out there. You either take longer to do it, you do a worse job to do it, or you find improved methods. And that's where we're turning to AI. We're turning to AI to find improved methods to provide benefits and improve outcomes, in this case, in healthcare. We're a little disserved by treating AI as one bucket of stuff, because AI is really, in truth, as Dr. Cutler started off with, talking about the different methods and the different uses. Dr. Nelson talked about we have to be very specific about the use cases. But if I'm treating AI as one big bucket, the best definition I think of is they provide human insights at machine speed. So can we do things that we normally need humans to do, but can we do them in a better manner? Can we do them faster? Can we do them more efficiently? I think Dr. Cutler said, electrons are cheaper than people. I thought that was actually kind of nice and or helpful to keep in mind as how a reason why we go forward with this. So in practice, rather than being a bucket of artificial intelligence, we use AI to get the right piece of information at the right time and put it in the right place. We use it to discover information that we otherwise wouldn't be able to surface. We use it to get information from a patient's medical record in front of the doctor when it's important. We use it to identify obscure research or help develop new compounds. We use it to generate communications with patients. So rather than just kind of it's all AI or one thing of AI, it's all these different techniques, it's all these different approaches, and the use case very much matters. And so we care a lot about the use cases, the risk management, and the important elements of that when we design and leverage AI. Because the same basic technology that we can use to predict what movie you might want to watch, what song you might want to listen to, what you might want to buy, can help predict the onset of disease, forecast the cost of care, recommend treatment options. And in theory, we can use AI to predict pretty much anything that we are able to collect data on. Now, that's whether an image looks like a tumor, whether a patient is likely to develop a specific disease, or even if a patient's going to show up for their next appointment. So these are all things that would help advance care and health outcomes across the nation. I want to talk about a few of the things we are particularly excited about at the department. We are excited about AI-enabled technologies in a number of near-term areas. So if I think of that far future versus near-term, we are very interested in using AI to improve clinical outcomes by providing high-value decision support tools while identifying and mitigating errors, knowing that we are working and augmenting human systems that also have errors in them already. We're excited about the opportunity to accelerate scientific breakthroughs that ultimately increase treatment options, increase quality and quantity of life. We're interested and excited about reducing clinician burnout by allowing greater time to be spent on care with the patients. Again, getting the information in front of the clinician, they don't have to go dig for it. They don't have to spend time finding it. Also can help a lot with routine patient communications and just engagement. Hey, reminder about your appointment, or received your message about, being late, kind of getting back and forth with patients on that. And then really importantly, empowering patients through improved health and human services benefits delivery, and really plain language explanations for what is this and can be complicated human services and healthcare system that we have, being able to translate what these things mean and empowering patients to be able to make decisions for themselves. So for the department, our priorities and kind of how we're approaching this is through the executive order on safe, secure, and trustworthy development and use of artificial intelligence that the administration released again in October. And that's following on the great work that Dr. Nelson did on the framework for AI Bill of Rights. We're prioritizing 5 activities over the coming year, working on developing resources and policies to enable safe and responsible use and management of AI. We're working on advancing the quality and safety of AI in healthcare through assurance standards and quality management standards and processes. We're working to leverage our grant making and contracting efforts to advance the development of responsible AI in health and come up with the answers for how do we do this responsibly and how do we do this well. Working on public education across the healthcare ecosystem to help constituents, clinicians, doctors, patients understand the engagement of AI in the health system. And we're working to evaluate and deploy AI across our enterprise, across the organization, to help the government and HHS drive process innovation and really improve services and mission delivery for the public. In taking together, this will enable the department to mobilize, all the components of the department to improve our services, our mission delivery, and get people in the nation into a healthier space. So with that, I just want to, come back to, I think, the premise, the title. We're looking at the promise and peril of artificial intelligence, and there is a lot of promise, but we have to be engaged in the discussion. We have to be engaged in doing it right and properly, and ensuring that we are taking care of the equities and working to address the isms, the biases, and ultimately coming up with tools and approaches to improve our health systems, our health organizations, and the health outcomes for the nation. So that I'll turn it back over to Jennifer and look forward to the discussion.
Thank you so much for that. Another fascinating way to start this conversation. And I appreciated the near-term look also, by the way. Those are helpful to those of us who try to write about these things. So let's move on to our discussion now. So as a reminder, everybody, we're going to turn to audience questions when there's about 20 minutes left in the program, but you can start submitting those anytime using the Zoom QA function at the bottom of the screen. That's where I'll be looking to see what you all want us to talk about. So building off what everyone has said here so far, AI already plays an important role in public health. Things like diagnosis, drug development, disease surveillance, so much more. But the list of reasons to be cautiously optimistic or just plain cautious is also pretty long here. So I'd love to start off just by hearing a bit more from each of you about how you're interacting with AI directly in your roles at present and what you're most focused on. Dr. Nelson, if you want to go first.
Sure. Yeah, happy to. Those were great presentations, Greg and David. Thank you. So I am back in my academic role and here at the Institute for Advanced Study. And one thing I've done is to start a multi-sector working group that we call the AI Policy and Governance Working Group. And part of what we're trying to do is bring people together from industry, from civil society, and from academia to sort of think about what we agree upon. I mean, I sort of mentioned at the top some of the reporting about all of the things we don't agree upon and sort of what are areas of consensus from the expert practitioner and research community that we can, sort of lean into. So I think that's important. I think in the scrum of all of this is, I think, still a lot of confusion on the scientific side, that we're still, there's a lot of the science, much like we've invoked COVID-19 a few times, much like that sort of all of those preprints, all of those draft papers, there's a lot of still early knowledge production taking place. And so I think working together to try to get a handle on that is really important. And then as part of the work of the working group, we also do a lot of public engagement. So we do public events around that as well. So that's, and then, I use some, chatbots in my day-to-day work as a scholar, but, that's my engagement there, really trying to think about across sectors on certain use cases. What are the guardrails? What are the new tools? What are the pilot studies? What is the research that we need to be doing to advance the field?
Mm-hmm. Dr. Cutler?
Yeah, so I'll pick up on a couple of themes. One is partly in research, what I've been doing is I've been trying to talk with various healthcare organizations as they contemplate diving into AI for different things, and then to try and understand how it goes. Just like implementation is not as easy as say, starting a patient on a drug where you go to the pharmacy and you get the pill and then you take the pill and so on, but it's actually like a very complicated process. But I'll just give you, I think what actually may be more informative. So I'm an academic, I teach, I do research, I have students and courses and so on. And one of the things I can totally sympathize with healthcare, because in academia, we are facing the exact same challenges about how do you use AI for beneficial things and how do you use it for not so beneficial things. So the beneficial thing is, gosh, you've motivated a student to be interested in a particular problem, and now they can use AI to help them learn about the problem and to research it, and much easier than they could do it. And the pitfall is like, if you're not careful, they'll start their term paper the night before it's due, and they'll go into ChatGPT and say, please write me a term paper. And then out will come something. And they haven't learned anything, and it's just an easier way of cheating than it used to be. And that's not, we don't worry about exactly the same thing in medicine, but we do worry about things like that. Like, when is the AI just going to substitute for what is the real hard work and the thing that only people can do? And how to combine the ChatGPT with the individual's knowledge so that they can do well, and so how much are we sort of saying, go for it, do all that, do all this great stuff, and how much are we there with the broom saying, I better clean up this mess that you left behind, and now you've given me this problem that like I haven't had, and they've come up in some of the chats, about liability issues and about workers who are displaced and so on. And like, and you just got to bring your big broom behind. And so I think I have maybe a little bit more of a sense of how the struggles that are going on, because I'm in a related industry to the medical care one.
Makes a lot of sense. Mr. Singleton, did you want to chime in?
Sure. Yeah, I mean, looking at how we're engaging on AI and what are we focused on, it really is quite a lot as a department. I think at the top level, it is kind of iterative, deliberate, risk managed approach to AI, looking at the challenges in front of us today. How do we address those, learn from them, move on, and kind of grow? But overall, our activities are guided by the Executive Order 14110 on safe and trustworthy use of artificial intelligence, where across the administration, they assigned some 150 deliverables and assignments out to different departments. We as a department were fortunate enough to have, I believe, 16 assignments come our way. And so we're really focused on those and delivering those over the coming year. And those are things like developing a strategy and framework for leveraging AI in public health and health benefit systems. Looking at quality assurance plans, how do we integrate and think about AI when we look at drugs or device development? We're looking at elements of artificial intelligence and enhancing or improving non-discrimination and non-bias aspects of the law so that they still apply when we look at artificial intelligence. We are broadly looking at our department as a strategy, both internally and over the coming year, developing our approach to helping shape the sector's approach and sector's engagement of AI. So we are doing a lot through that strategy, overall working to understand what's the sector doing now, what is the sector focusing on tomorrow, and then engaging with the policy community so we can help shape and steer that in productive ways. So really quite a lot, but again, the short version is, what's in front of us, deliberate, cautious, judicious engagement and continued learning.
Well, sticking with that word cautious, generative AI is having its moment. How do you see it being used responsibly within public health? And that question is for anyone who wants to take it. Or perhaps no.
So yeah, I can take a crack at that. I mean, one of the one of the key areas of public health is engaging with the patients and the population and helping them feel empowered and confident in their care, in their level of knowledge, in their being part of the discussion about how they're feeling. There are a number of areas where, at least frankly, even pretty soon in the near term, we can leverage generative AI to translate documents, to engage increased populations, to provide information to people in an accessible form. There are the opportunities to structure generative AI to digest and provide information to people in forms that they can, understand it, they can get access to it, and provide kind of steering to people so they can engage with the system. There, in maybe a little further out, there are opportunities for some of the AI mechanisms to be, in some cases, like a patient navigator or something that helps somebody get through the healthcare system that we have. So there are a lot of opportunities here. The question, as always, is how do we do this safely and responsibly and cautiously and kind of proceed in a stepwise manner so that we're managing risk.
Right.
So I was part of a survey that was, we recently did a survey on uses of AI, potential uses of AI and barriers to AI use in healthcare. The group in healthcare that's most eager to use AI is insurers, payers. And they want to use it to streamline some of their things like prior approval processes. So they get a request from a doc to do something and they want to have the AI look at it and decide what to do instead of always having a human look at it. So that's sort of the first use. And they're sort of gung-ho about that, and they're prepared to do that, and they're just, finding the right systems and so on and so forth. On the medical provider end, there's a lot more skittishness. So they would like the AI to be helpful. They're worried about all the things that my colleagues were saying. They're worried about the confidentiality. They're worried about the making up data. They're worried about the patients and their reaction to it and so on. And so what I think the provider community is sort of looking for some, like, if you will, guidelines about here's how you should do this. Here's the safe things to do. Here's how you should interact with it. I think there will be some leading edge folks who say, hey, great, we're going to go with it. We're going to try and figure out what to do. But I think there are a lot of folks who are, if you will, waiting for either the federal government or someone to come along and say, this, we believe this is fine and you should come ahead and do this.
Makes complete.
If I could jump in, Jennifer, I don't know that we know yet that generative AI, if you're talking about large language models and you're talking about the use of multimodal, foundation models, can be used responsibly in healthcare. Actually, I think that's an open empirical question. And I think right now the answer may be no. I think we have seen both in the New England Journal of Medicine and also in JAMA articles that showed that there was, racial bias in large language models that were used to ask questions by healthcare providers. I mean, I think Greg is right that translation is, I think, probably the best case scenario. But I think even sort of ingesting large documents, we face the challenge of, on the one hand, you're trying to solve the problem of like, what do I do with all of these records? There's, thousands of pages, tens of thousands of pages. But then we've got the challenge of the fabrication and the hallucination, and you actually can't check the distillation to know that it's accurate because you've not been able to read the 20,000 pages or whatever that it's distilled. And so we find ourselves, and I do think there needs to be a higher duty of care and a higher barrier in healthcare. It's just too important and the stakes are too high. And I think it's also, I raised the issue of professional ethics because, particularly if you're thinking about the Hippocratic oath and you're thinking about physicians, right, do no harm. How do we think about using a tool that we know can be inaccurate? Like, I don't know how as a physician, you obviously are looking for better outcomes. You hope it's going to make improvements for your patients. But you also know that the tools don't always work or work at the level that you would feel comfortable with. And so I do think, again, not providing any answers, but I think that it poses for medical professionals a real ethical quandary, particularly for generative AI. If you're talking about deep learning or neural networks or things that are not intended to generate new things as part of the work that they do. You're talking about radiological imaging or imaging of lung diagnoses, as I mentioned, for COVID-19. Maybe that's a little bit different, but I think generative AI is a struggle for public health, I think.
Sure. I certainly heard plenty of interesting things around using generative within drug discovery within these very narrow, right, types of frameworks. Equally, I live in New York City, and there was a very carefully trained chatbot that was providing advice that's actually against the law. So for whether to accept Section 8 housing, things like that. So it's hard for me to imagine, but I wanted to ask if people were working on things or knew of things. Getting back to those guidelines that Dr. Cutler just raised, as is often the case, technology is vastly outpacing the frameworks that might shape its development, legal and ethical. How concerned should the public be about that right now? How concerned are you about that right now?
Well, it's something that we are keeping a close eye on as we look at the evolution of these systems and look at the evolution of practices in the sector. And I think there are a few sides to that question. One is certainly the intentional, legitimate use of AI in delivery of care, in provision of trustworthy services to clients. There's also the possibility for others or outside actors to use generative AI in perhaps harmful ways to cause problems that we are also taking a look at. It's something that right now, with how the tools are being used, again, as people are looking at and focusing on these specific use cases, what are they doing with the AI? What's the risk if it goes right? What's the risk if it goes wrong? But then there's also, how does this compare to the existing system? There are systems that, okay, if it gets a citation wrong or it hallucinates one element of a conversation, but your existing clinician may have a higher error rate than that, or your existing folks may be tired, or maybe biased in their own right. We've seen some studies where, since the electrons are essentially free, in chatting with patients, some of these chatbots can be more empathetic and leave the patients with a greater feeling of care engagement than you can from a normal clinician. So we just always have to be comparing to the existing system that we have that is not perfect, not comparing and looking at the existing system as if it's perfect and flawless. So I think the perspective is, do these tools right now, and by the way, these are kind of Gen 0 tools, they're first generation, they will be improved, they're going to be refined, there are a lot of trials going on trying to work on that. If these systems can be used to improve the overall system that we have today, then great, let's go forward with it. But if we're not able to get them to work, if we go through these frameworks, the train system, the group, the CHI group, other folks that are looking at these, and we find that we can't use them comfortably, reliably, in a trustworthy manner, then no, it's not something that we proceed with. But it is something we are paying very close attention to and is part of our everyday discussions with the technology sector, with the medical sector, clinicians, and the public.
In my mind, a very good guide is to follow the money. So whichever way the money goes, think about that. So these things will not, I think, just appear randomly, but wherever the financial use cases will be high on the list, hopefully we'll have at least some resources to think about clinical and non-clinical use cases where there isn't much money, but where we could still do a lot of good. But I would really look a lot at what kind of incentives get put in place. And I think folks are really still trying to work their way through that. And so helping that, I think, will really help shape which way, where we see the biggest issues and both possibilities and pitfalls with AI.
Yeah.
Can I follow up on that? I mean, I love where Dr. Cutler's going. Part of the work that I was doing when I was working as a technology science advisor in the Biden administration was helping to usher through ARPA-H, which is this endeavor. I mean, I think the incentive structure piece is so important. And I think in the context of public health, so not just medicine, but public health, there are lots of things that we want medical technologies to do that might not necessarily, they're effectively market failures, right? They're not going to make money for a company, but they might do a lot of good for a lot of people. And so, I'm glad that David raised that, because I think it's that particular incentive structure for these particular technologies, I think, is something that just still remains to be thought out. I mean, we are living with a major technological transformation driven almost solely by the private sector, right? So, we've got, Mariana Mazzucato and others have written about the investment of the federal government through DARPA and other agencies that got us to GPS, that got us to the iPhone and these sorts of things, with things like generative AI driven almost solely by the commercial sector. And so the incentive structure is vastly different. It's you've got to keep companies in business and keep, startups afloat and these sorts of things, which is a different proposition for something like public health, which has a very different mission. And so, I think there's a kind of misalignment there that it's worth just actively, I mean, it's fine. We've got a lot of market misalignments all through society, but it's just worth, I think, sort of thinking about that specifically. So you asked about policy, sort of keeping up with the technology. I just wanted to raise two other points. One, about this technological transformation being driven by the private sector and or by industry, which is fantastic. Innovation at its best is fantastic. But these are also disruptive models. Like, in some ways, the whole purpose of many of the models in Silicon Valley is disruption. So if we think of the case of Uber, Jennifer, I also spent a lot of time in New York City, although I'm in Princeton today. It was getting around the taxi medallion system, right? And so the disruption, so when we say that government's too slow, sure, sometimes, but it's also the case that the industries are set up and explicitly to get around regulation, right? So you can't be surprised and say like, oh, they're behind with regulation when the whole sort of raison d'etre of a particular business model or business strategy is disruption. The other thing I would remind colleagues, people of here, as a former government employee that always wants to defend the great work that's going on in Washington, is that there has been legislation to help us put guardrails exactly like we're talking about for years in Washington, right? There have been people advocating on the Hill, staffers, legislators, for data privacy for at least 4 years, 5 years. I mean, longer, but and then in this more immediate kind of AI conversation. And so it is not that legislators don't actually know what are the kinds of regulations that need to help to keep up with the technology. It's like we don't have the political will to get these things done. There have been very good bills around algorithmic accountability, around data privacy for several years now. That would have anticipated and could have been in place well before generative AI kind of emerged in the fall of 2022. So I also want to keep that piece in mind as well.
Absolutely. And there's also another element, I think, too, not just people going around regulation, but I often say we needed to drive before we decided seatbelts would be a great idea. It's like some of this will be, a little bit of catching up. As everybody is kind of poked at a bit, but I think we should really raise forward. AI has the potential to help break down tremendous barriers and help many, many more people gain access to care. Unfortunately, it also has the potential to make this process even less fair than it's been. So, Dr. Nelson, specifically with your work, do you have specific suggestions for how we make sure we get that first outcome? Things that people can begin working on now?
Yeah, I mean, I think that we have got to think about the full technology stack, right? You need to be thinking about these issues around risk and harm. I mean, the way we get to benefits is by mitigating the risks and the harms. And we need to be thinking about them literally at every stage of the design and development of technologies. And to anticipate that they're likely to happen. So, training data, whether or not it's scraped, with claims of violating IP or not, I don't know, we'll leave it to other people to litigate that. But data sets come with various kinds of constraints. They've been demonstrated to have biases around race, around gender, and other issues that matter for public health in ways that they might not in other kinds of spaces. Like, the same training data set sort of used for, a recommender algorithm on social media, like maybe we don't care, but I think when you're dealing with the stakes of public health, we've got to ask those questions. So in the design space, how are we thinking about whether and how we're mitigating bias. And then when you get to the developer space, like, are tools being risk assessed? Are we auditing them before they're released to make sure, to the best of our ability, right? You can't foresee everything, but has like sort of good faith due diligence been done before tools sort of enter and systems sort of enter the scene? And then after they're released, particularly when you're talking about more general purpose AI that can have a multiplicity of use cases, then you've got to dig in and sort of be watching to make sure that there's not risk and harm in all those different use cases. I mean, we're talking about with large language models, things that might be used in public health, but also in education and also for leisure time. And the sort of risk calculus for all of those is completely different. But I think we have to move out of a space of, like, if you think about the FDA, this is a medical device, we have approved it for all time for one time, to sort of a much more dynamic and nimble way of thinking about how we're keeping an eye on sort of more dynamic and iterative AI systems.
Yeah, I want to get to questions from the floor. One more quick question, though. I don't know if it's quick. Sorry, Dr. Cutler. Let's talk about jobs. I think I framed that as quick, but many of us are here. We're familiar with the example that Dr. Nelson gave earlier about radiologists. They were predicted to have largely been replaced by the tech. Instead, we dealt with a global shortage. How do we deal with such uncertainty, and what should health systems be doing right now to prepare, given this?
On the clinical side, my guess is, at least for the short term, AI technology will complement and not substitute for clinical workers, because you're going to need the clinical worker for liability reasons, because the doctor knows more things than the computer knows, because the doctor has seen particular circumstances or can recognize particular constraints and so on. And that was, I think, what Dr. Nelson was talking about in terms of some of the recent studies. The computer and the doctor bring different things to the table. It's not just one is a substitute for the other. So there, I think, I'm not worried about mass unemployment of clinical personnel. On the administrative side, there may be more substitution. And I do think that there's some administrative personnel who may be duplicative of things that AI can do. I also think that the administrative side are areas where we need a lot more people to be doing stuff other than just administration. So, for example, we need more outreach to people in the who are having difficulty coming in, or we need more people to help monitor chronic disease stuff. And a lot of the people who are involved in medical records coding and billing and so on actually have skills that would be quite transferable to where we need people, but we haven't been able to have them and stuff. So I think that we're not going to have mass unemployment of people, because the phase-ins are going to be gradual and so on, but that what we could have is a redirection of some of the administrative work that's going into work that's somewhat more patient-facing and hopefully focused more on how do you deal with the patient in need, so that you're not there answering the telephone, which doctor should you talk to, or how should you submit this bill, but you're instead like, okay, these are what the history of the test results are, and so let's figure out clinically what to do, but let's make sure that things are going the way they should, or that the plan that we have in place is working appropriately.
That's something I've been waiting, I think, to see just more broadly in the economy. I think instead of chasing that idea that we've had for 5 years, that we've not had the manpower or the people power to go chase, we've been largely cutting. So wouldn't it be nice, instead, we're not going to cut our way to greatness. Maybe we can do some more redirection and take advantage of these opportunities. Now, going to the questions from the floor, a lot of people are offering this variation on a similar one. So I'm just going to mash them together and offer this one up. How is an AI system created to be without isms when the creators have their own set of isms? Or, for example, how do we prevent AI bias if the people who teach the AI have biases?
So I will offer perspective, and that is to say, we are at the early phase of these technologies. We have goals in sight, and the goals that are laid out in the executive order: fair, trustworthy, safe artificial intelligence. And what we are working through and what we're developing are the processes to get there. And it will take experimentation, it will take learning, it will take development and communication. I think of it a little bit like baking a cake. you have ingredients, you have your process, and then you have your outcome. And we are working across those dimensions of data reliability, data collection. We're working on the model development processes, other things. We're working on the measurement and understanding the outcomes and how they match to our goals. But ultimately, we are working through that process with those goals in mind, as in ways that maybe we aren't with the existing systems, or the existing organizations aren't able to fulfill. So being able to measure things through AI allows us to constantly work to improve, and ultimately with the goal of getting to AI that reflects American values.
Anybody else want to jump in before I go to the next?
I'll just add one thing to what Greg said, which I think is very important. Outside of government, healthcare is a very sort of prove it kind of industry. You don't get to just make a claim. Your claim has to be published, and it has to have been done in a clinical trial, and it has to so on. And so I think that's going to help us with this, because I think clinicians are rightly skeptical about someone just coming in and announcing, oh, I can replace, this task you've been doing just with this program, and just trust me. And they're going to want to say, no, show me the evidence for that. And then you're going to have to generate the evidence for that and stuff. So my hope is that as a community, we can hold the ground firm in terms of, these are what we expect. We expect it to be accurate, and we expect it not to hallucinate, and we expect it to not discriminate against people. And if we find that, we're going to fix that, or we're going to deny it, or whatever it is. And these are what the expectations are. And I think the federal government, with its recent report, has laid some good goals that we can then try and translate into how to make that happen, so that there can kind of be a standard setting, kind of like, a little bit like what the FDA does, which is certify that, yes, when they said this trial did this and found this, that's really what that trial did and found. And then on the weight of the evidence, you can make a determination or not. Sometimes you get it wrong, but at least the goal is to try and always make a scientific determination about what's right and wrong.
Excellent.
Yeah, I would just double click on both what Greg and David said, and just say again, the challenge that we face with AI and generative AI in particular is that it's dynamic. And so you can't just do it once. The sort of, the FDA model, has often been, you approve the medical device once and off you go. And I think that we need to build, figure out an ecosystem that allows for the sort of empirical science-based checks that David's mentioning throughout that whole stack, throughout that whole life cycle, which is the design, development, and deployment. And so to the question that you synthesized from all the other questions that have been coming in, any designer of any tool is going to bring their own, sort of isms, their own sort of perspective to the work. But it is the case that we can do a better job before we release these tools of knowing if that's the case. So we might think about sort of the use of vision-based AI. There were viral videos of people with dark skin trying to use, sort of AI-powered, faucets to wash their hands, right? Just merely because they had not been tested. That's just a basic design failure that, the companies should, we should expect much more than that from products. And so I do think that there needs to just be, to David's point, a real transformation, and the responsibility that I think designers, developers, deployers feel is theirs. And also, and thank goodness we've got Greg and others working in this new important role of the chief AI officer, on the government side, putting a check on that.
Another question from the chat. We have, who should be held accountable in cases of errors or adverse outcomes resulting from the use of AI in healthcare, particularly in scenarios involving autonomous decision-making? Anybody want to take a stab?
In the regular, go ahead, Greg.
No, you go first.
This is your job. This is your job.
Well, that's why I'm hesitant to say who it should be. I will just observe that there are very few cases in the economy where we absolve folks from liability for things that they participate in, and that they, responsibility tends to lie and stay with designers, developers, organizations, clinicians, it's a shared responsibility chain based on roles and I don't expect that principle of US law to really change too much there.
Yeah, that was my question around autonomous decision-making and how we define that. Dr. Nelson, you wanted to chime in?
Yeah, the only thing I would add, as someone who can speak more freely than Greg, released from the strictures of government, is that it's hard to know. I mean, the challenge that we have faced with increasingly more sophisticated algorithmic systems is that we have no visibility into them. And so you also don't know how things happen, at what stage they happen, when, if something goes wrong on something that's built on top of a foundation model, how do we think about third-party sort of actors in this space? So we've got a lot of, I think, fresh unanswered questions still to be answered around liability. We had, similar ones with predictive algorithms, right? Some of the ones that were used more generally came out of meteorology or seismology, sort of like, the large chaotic sort of systems, and became used for things like recidivism prediction, right? And so you could sort of track those a little bit more, but you still we often just don't know what's inside the black box. And I think it makes the liability question a bit more difficult than it does with some other medical technologies.
Sure. Let's scrolling down here. We have folks who would love to hear the panelists' thoughts on regulation of the data being used to train the models. I was thinking about Colorado, if anyone saw that in the New York Times, was it last week, on brain data, as the state begins to think about what it means in that case. If anybody has something they'd like to share, by all means, take the floor.
Just to start off, I want to come back to one of the issues that we came by briefly, which is we want the data to be trained on what is the truth, not what is the physician's perception of the truth.
Mm-hmm.
Because the physician's perception of the truth has a lot more stuff built into it that may not be the actual truth. And so I really think about doing things on the basis of ground truth. But so for example, predicting who's going to have a cardiac event. I'd rather base it on who actually has a cardiac event, not on a physician's, not can I reproduce the physician's perception of it. But I do also want to be cautious, and it comes back to this sort of isms discussion, which is sometimes the ground truth itself can be biased. So for example, there was the example that was written up in an article in Science about a company that was trying to reduce readmission rates to the hospital or post-acute spending, sort of people who had an acute event and want to reduce post-acute spending. And so they wrote an algorithm to try and predict who would be a high post-acute spender, and they did not include race in the algorithm. But nonetheless, the algorithm sort of figured out that white patients use more care than Black patients. Therefore, you should clearly intervene if you're interested in saving money and follow-up care, intervene relatively more for white patients than for Black patients. I don't know the actual truth, but I'll give the company the benefit of the doubt, which is say they had no intention of writing an algorithm that would favor white patients over Black patients. But it's still, in that case, the actual honest to the goodness truth was that white patients used more care, not because they needed it, but because that's the way the system was. And so there, I really want to think about the truth as not being I want to save money, but the truth as being I want to improve the health of patients. In which case, then I really will think about the various health problems, assuming I can, of course, measure them, not the diagnosed health problems, so not the physicians telling me what the health problems are, but the actual health of the individual. So I think it's going to be very difficult. But my brain keeps coming to this, what is the honest to goodness truth about the world? Not what is it that someone is reporting to be true.
And how you capture that. I think about this in terms of women as well, or with synthetic data. It's I feel we could have an entire conversation just about that. We have one here that says, question to Dr. Cutler. You said as an example that you'll be happy to see AI doing bills because it is cheaper than people. Does this mean that AI will eventually replace some of these jobs? Or is your prediction on the outcome of the financial, medical, paramedical, administrative workforce, whether that, at the university health institution level or at a national level?
I do think the AI will likely replace some people over time. And I think, as we were talking about, I think and I believe that there are plenty of things that people need to be doing in healthcare and in related industries of public health, community health orientation, where people with skills like those that are doing medical record keeping and coding can work, that would be extremely valuable for folks. And having very, very dedicated, loyal workers doing that is, I think, a waste of many people's talents relative to what they could be doing.
We have a
And
number.
of course, I mean, of course, we can also, there's probably a litany of jobs that we can't even imagine. I think that will be, produced out of this transition. So, we can think about now the sort of emergence of prompt engineering as a kind of role, I think. So you could imagine if decisions are made in large health centers to use large language models with the understanding that they've got a challenge with accurate information, sometimes half accurate information, then who are going to be the people that sort of help to suss that out in a system, for example, so if we're going to sort of stick with the systems that we have and introduce them into public health, there's going to have to be, lots of different guardrails, including, actual people, I think, testing them. So that you could imagine sort of medical, prompt engineering being, or public health prompt engineering being a whole new kind of a role that takes a particular kind of expertise, because you would want people with subject matter expertise to prompt the tools for the things that would be prompted in a public health space, as opposed to just, kind of general conversation for the broad public. So, and we saw this, of course, with also with automated cars. Are we getting rid of all cars and drivers? No. And in fact, there were still actually some humans helping these automated cars be on the road. So I think we can't, we shouldn't only predict that jobs will be lost as a function of this transition. And I would also point back to President Biden's executive order on work in particular that really, asked the Department of Labor and others to look at ways in which, job loss could be mitigated. Like, are there, how can the federal government be supporting reskilling, upskilling, and sort of creating a job ecosystem that's not just tremendous job loss for a large amount of people.
Yeah. A number of people on this call would like to know if you have any favorite resources, perhaps, if they're looking to further educate themselves in this space of AI within public health. Put that out there. There's also a number of people wanting to talk about recommender systems and predictive analytics, particularly ones that could be used to reduce cultural disparities in access to care or levels to care, if anyone has something to add about that.
I would just offer, the Journal of the American Medical Association's done a really excellent job, I think, of doing work on AI and its medical implications. There's a whole series that started last year. There's, I think there's videos and interviews and the like. I participated in that. I think that's a good resource.
NEJM has also, I love the JAMA one. NEJM has also started a NEJM AI, which is, which I find to be particularly helpful as well.
I have an interesting comment here as well from a woman in South Africa who says, on the one hand, we have challenges with electricity supply in our healthcare facilities, but on the other hand, we're using AI to assist with TB diagnosis in our x-rays. To what extent are African institutions being included in the emerging networks and discussions such as TRAIN? If anyone.
I don't know. I mean, Greg, you might know, you might be tracking this closer. I think TRAIN's American only, although I imagine many of these health systems are multinational, but I don't know.
Yeah, I think, it is early days for these efforts. There's a lot of work being done, I think with OECD, with the European Union, with the UN, around kind of the AI development. I will say, I know that we also have programs at NIH and others that work to engage diverse institutions, diverse researchers, and help facilitate kind of that engagement with broader communities. So I know we have programs there. I don't know specifically to the direct question on the African-based institutions.
One of my hopes, without answering the specific on those institutions, one of my hopes is that we'll evolve a system for AI like what we have for drugs, particularly essential medicines, which is that we, the world, basically agrees we will sell them in the poorest countries for cost. We will give them away. As long as someone will pay the cost of physically producing the drug and getting it there, we'll just give it away. And no, we're not going to make money. The world is not going to make money off selling drugs in essential drugs in poor countries. And I think we should have the same view about diagnosis, about AI operations, TB testing, all the rest of it in low-income countries. That's not a market that we want to make money in. We want folks to. We just got to cover the cost of getting it there, and then it's going to be free from there on out. And then if you're in a higher income country, fine, you have to pay for it.
All right, so we are basically at time and we're going to need to wrap up here. Thank you, everybody, for joining us. Thank you to our esteemed panelists. This was my great pleasure to moderate this discussion today. Very much appreciate your time.
Well, first of all, thank you, Jennifer, for outstanding moderation. If I may, thank you to Alondra, Greg, and David for a really, really interesting conversation. And thank you to the audience. I thought there was this whole stream of both excellent questions, but also really interesting comments in the chat. I feel like it's a topic that correctly engages us all. And I feel like I leave this conversation both much better informed and also have more questions than when I started, which is perhaps how it should be for a topic like this. So I want to say thank you to everybody for engaging with this. Thank you to our panelists. Thank you to our moderator. And in particular, thank you to everybody in the audience who engaged with this topic. Everybody.